You're not audible.
How about now? Am I audible now? No?
Yes. Now audible.
Okay, great. Thank you,
Yes.
Dr. Ritul. It's okay. My apologies for sending in such a long CV. I should send in
No, that's okay. Perfectly okay.
But thank you so much. I think we'll move on for a short of time. So, with your permission, shall we? I'll go ahead and start.
Yes, of course. Please.
Thank you so much. So, very good evening, and I'm so happy to be part of the RSSDI 2021. Is my first slide visible? Just to confirm that I'm sharing properly. Is it seen?
Yes, it is visible. Yeah, visible.
Thank you so much. Thank you. So I bring greetings from Chennai, where after a bout of darkness and rainfall today, we see bright sunshine. So anyway, so good evening to everyone. I'm so happy to be part of this particular symposium with women with diabetes, and it's been a pleasure to listen to the previous talks as well. I'm going to be further discussing what has already been previously discussed by Dr. Chitra in her talk. I'm going to be discussing cardiovascular risk in women with diabetes. Is it more than what we think? And are we, as clinicians, guilty of not taking it too seriously? So I want to start off with a case study, which is, I think, my usual approach to this particular topic that I usually try to, because I think this is what sort of makes it relatable for many of us as clinicians. So this is a 51-year-old lady who is a farmer, who's a wife of a farmer, and she's a mother of 3 living in a village. She's a known case of type 2 diabetes since 13 years, and she's on medication for her diabetes. She's on a sulfonylurea with metformin. She presents to a doctor with pain in her upper back and shoulders for the past 2 days. And the doctor prescribes her a set of painkillers and sends her home. Day 4, the pain still persists and she develops vomiting and returns to the clinic when the doctor decides to take an ECG, and then it turns out to be an evolved inferior wall MI. So this is a very common sort of clinical scenario that I think, which is probably a very sad story that I'm starting off with. But the sad truth is that women are often dismissed. And there is data to show that women in general are under-investigated for the presence of coronary artery disease. And it is quite sad that, but this is the stark reality of the world today. So moving on, what is the data that we have? The prevalence of diabetes globally, as we all know, has been increasing. But this is data, Indian data, where I'm showing you the prevalence of diabetes in the adult population in southern India, reported right from 1980s right up to 2016. And as you can see, there has been an explosion in the prevalence of type 2 diabetes over the years, and this is likely to probably keep increasing. What is alarming is that this has been increasing not just in the urban areas, but also in the rural areas. When we compare our data to that of global data to the other parts of the world, and when we tease it out further between men and women, the prevalence of the percentage of prevalence of type 2 diabetes comparing both men and women, as you can see, the blue, which represents the men, and the pink bars, which represent women, the blue bars are slightly higher in the western part of the world. But when we look at Southeast Asia, we find that women, the percentage of growth or the percentage of increase in the prevalence of type 2 diabetes, and this is data right from 1980 to 2008 by region wise. And in Southeast Asia, the percentage of increase in the prevalence of type 2 diabetes is actually higher in women as compared to men. So we are still probably, we should come out of that belief or the disbelief that women are less affected with non-communicable diseases or lifestyle disorders. This is data that we recently published. When we move on to, again, we looked at data from Southeast Asia. Now we're going to look at data from our own part of the world, from India, from Tamil Nadu, where we looked at the change in prevalence of type 2. So we had last published data on the epidemiology of type 2 diabetes and cardiovascular risk factors from Tamil Nadu last in 2006. So we wanted to go back and look at the trend of these risk factors, namely cardiovascular risk factors, both diabetes and prediabetes in the same population 10 years later. And we call this the so-called STRIDE study, looking at the secular trends in diabetes in India. And these were the results where we found that there is in fact a significant increase in the prevalence of type 2 diabetes in not just in the city and in the town, but also in the villages. And what I want to bring your attention to is that last bar that you see in the bottom, where you find that there is a significant increase in the prevalence of type 2 diabetes in women, again, not just in the city, not just in the town, but also in the villages. And this is how this becomes very relevant to that case that I presented to you earlier, where there's a woman with type 2 diabetes who presents to the OPD with a myocardial event. Moving on, when we also looked at the prevalence of prediabetes, similarly, we found that there is in fact a significant increase in the proportion of women with prediabetes. And this is again, not just in the city and in the town, but also in the villages. So what is worrying about this data that we're looking at here today is that we have a huge burden in the prevalence of prediabetes as well as diabetes. And what is so important about prediabetes is that these are women who are waiting, or a sort of like a ticking time bomb, who are waiting to convert to type 2 diabetes. And we all know that once they do convert to diabetes, it is almost considered as a cardiovascular equivalent. We also published the trend in cardiovascular risk factors, and this is what is even more striking, where we looked at data in the trend in CV risk factors among women, the same STRIDE study in which we looked at over the past 10 years, whether there is an increase in the cardiovascular risk factors. And we found that there is in fact an increase in the prevalence of dyslipidemia, again in the rural women as compared to the urban men, so 37% as compared to 29%. Again, there is also an increase in the waist circumference. And here you find both in the urban and in the rural, there is significant increase in the waist circumference in women in the rural population, a significant increase in the general obesity. And when it comes to hypertension, we found that there was a significant increase only in the urban, but not in the rural areas. So this is the burden of cardiovascular risk factors. And I presented to you data globally. I showed you Southeast Asian data, and right here in front of us, we are now looking at data from our own part of the world, Indian data of this latest data from 2016, where we find that there is a significant increase in cardiovascular risk factors among women. So this is very, very alarming and something that we really need to take very seriously. So is there, in fact, a higher cardiovascular? Now we looked at data to show us that there is an increase in the cardiovascular risk factor prevalence among women, but is the burden of cardiovascular mortality higher in women as compared to men? And this is a meta-analysis in which they have actually looked at all-cause mortality and cardiovascular mortality in women as compared to men. And this is a large number of subjects that they included, almost 23 studies and a huge number of subjects that were included in the analysis. And they looked at both cardiovascular and overall mortality and stroke mortality, and comparing that between women and men. And interestingly, when they looked at women with diabetes versus women without diabetes, they found that there was a 93% higher risk of all-cause mortality in women with diabetes versus without diabetes, as compared to a 74% higher risk in men with or without diabetes. Furthermore, when they analyzed the data between women and men with type 2 diabetes, they found that the all-cause mortality was 13% greater among women with as compared to men with diabetes. So this is what they found from the studies so far. Furthermore, in the same analysis, they also found, when they looked at, so far what I showed to you was data from the all-cause mortality, but when they also looked at cardiovascular disease and cardiovascular mortality, stroke mortality, they found that there was a significantly higher mortality rate, both not just all-cause, but also cardiovascular mortality in women with diabetes as compared to men. So this just, the authors of this the analysis and this publication actually conclude by saying that we probably do need a gender-specific risk assessment, and also our interventions and our approach should probably be more gender-specific. This is a study in which, quite an interesting study in which they looked at the 2-year mortality rate between diabetic men and women after a first myocardial infarction. And they found that after the first MI, mortality at 28 days and then further mortality at 2 years was significantly higher among women as compared to men with diabetes. And they actually concluded that the survival at both 28 days and at 2 years was actually lower in women, significantly lower in women as compared to men. And the authors also concluded that diabetes and cardiovascular disease was probably more dangerous in women as compared to that of men. So why is this so? So far we've established that we do have a huge burden of cardiovascular risk factors, type 2 diabetes, women exploding to convert to from pre-diabetes to type 2 diabetes. And we've also now looked at data to show us that cardiovascular disease in women is probably more dangerous than even men. But why is this so? Are there differences in the risk factors and the pathophysiology? And this has also been briefly discussed in the previous talks. But the cardiovascular risk factors are slightly different, quite different in women as compared to men. And this is because there are diversities in biology. A woman goes through different changes throughout her life cycle. There are cultural differences, changes in differences in socioeconomic status, which also impacts the women's health. And overall, there is also differences in body composition, which also I'll be showing you in the next couple of slides. So other than the traditional cardiovascular risk factors, which would include diabetes, obesity, abdominal obesity, smoking, hypertension, dyslipidemia, and so on, women also have the unique gender-specific risk factors, which would include gestational diabetes, their polycystic ovarian syndrome, low socioeconomic status, more propensity for breast cancer, depression, and all these, of course, menopause, postmenopausal women, all these factors together, which are gender specific, also contribute to CV risk factors. And so the risk factors itself are quite different. There is also a difference in the fat distribution, and this is a cross-sectional CT that you see over here, pictures, films that you see over here, where we're comparing both. On the left, you have A and C, which are men with a BMI of 25 on top, and the bottom is a man with a BMI of 33. And on the right, you have the same BMI, but women. So as you can see, there is women, it is well known that they do have a different sort of fat distribution as compared to men, and more propensity for visceral adiposity, or the more sort of dangerous fat, and higher cardiovascular risk as compared to men as a result. We also know that, and this is data to show us, that men have an earlier cutoff of age and a BMI for diagnosis of type 2 diabetes. So in other words, men are diagnosed earlier as compared to women for type 2 diabetes, because they have this could be because men have a lower age cutoff, men may have a lower threshold of BMI, lower threshold of insulin resistance, more because of the fat distribution differences. But this could also be because men have more health-seeking behavior, and men probably get tested more earlier or more often than women tend to. And as a result, women get diagnosed with type 2 diabetes probably at a later stage. And this indicates that women are at a worse starting point, or their starting point at which they are diagnosed with diabetes itself is a worse starting point as compared to that of a male who is diagnosed with type 2 diabetes. And we are probably starting off our preventive strategies for complications a little too late during the course of dysglycemia during a woman's life. So just to summarize what I've spoken about so far, there is an increase in the prevalence of both diabetes, pre-diabetes, and cardiovascular risk factors, including waist circumference and obesity in women in India. We know that cardiovascular risk and risk factors in women are quite different as compared to men. And we also know that menopause itself is one of the risk factors that increases cardiovascular risk in women. But if once a woman is diagnosed with type 2 diabetes, her premenopausal estrogen production is also probably lost. And we also have looked at data to show us that cardiovascular disease in women is probably more dangerous than that compared to men with diabetes. This is, I'm going to conclude my talk with this study, which I just included this morning in my slide deck. This is a review article that I quite enjoyed reading, which has been recently published in the Diabetes and Metabolism Journal just this year, 2020. And in this, this is a sort of a recommendation for management of cardiovascular risk factors or cardiovascular risk in perimenopausal women with diabetes. And it addresses, it's basically a call for clinicians to address or to sort of take women with diabetes more seriously. So lifestyle behaviors that are recommended is, of course, smoking cessation, weight reduction, physical activity at least 30 minutes a day, restrict salt intake, and increase your intake of fruits and vegetables at least 10 servings per day. Alcohol consumption recommendation is less than 1 or even up to 1 drink per day for women. Glycemic targets, of course, to be individualized and to use SGLT2 and GLP-1 or cardiac-friendly anti-diabetic agents when and whenever necessary. Blood pressure targets also to be individualized. Consider ACE and ARBs whenever possible, but contraindicated in pregnancy. Cholesterols, statins to be used in all women with diabetes. However, in younger women with lower cardiovascular risk or women with who are non-smokers and who are on intensive lifestyle modification and who are on good dietary regimes and who have low cardiovascular risk, as I mentioned, in such women we could consider not using a statin if not, and that is left up to the discretion of the clinician, but of course contraindicated in pregnancy. Antiplatelet therapy to be, the role of aspirin is not indicated in the primary prevention of cardiovascular disease, but any women with established cardiovascular disease should be on an antiplatelet therapy as well. So in conclusion, women with diabetes probably do need more aggressive cardiovascular risk reduction. And I would like to conclude my talk by asking this question: do we need a gender-specific approach? And I think the answer to that at the end of this entire session at the RSSDI today should be yes. Thank you.